So the title of my presentation is Progress and Future Directions of Targeted Combination Therapies in Non-Small Cell Lung Cancer, which is a very, very huge field. And so I just decided to talk about combinations in EGFR mutated patients and also something about KRAS, because otherwise 30 minutes were not enough, but I'm happy to discuss maybe during the discussions the other parts. Here you have my disclosures, and starting with the first big combination that you know better than me, because I see that maybe you see more EGFR mutated patients compare than me. I think this was the first presentation of the FLORA2 phase 3 clinical trial, randomizing patients to receive either osimertinib and chemotherapy over osimertinib, which is the standard of care, with the maintenance osimertinib pemetrexed and a reevaluation until disease progression. The primary endpoint is the progression-free survival, and the secondary endpoints were the overall survival, the response rate, and the duration of response. I think that this is a very important trial because the progression-free survival is 25.5 months. And if you remember, in the FLORA trial, it was about 19 months with osimertinib alone. And here we have a 16.7, which is just a bit lower compared to the FLORA2, but in any case, you can appreciate the huge difference corresponding to an hazard ratio of 0.62, which is highly statistically significant. What is very interesting is that differently from what we expected, the activity of the chemotherapy is very high also in patients with CNS metastasis at baseline. And always we have to remember that also pemetrexed is a good drug for patients with brain metastases. And in fact, you see that there is almost no difference for the combination with chemotherapy for patients with and without brain metastasis, with 2 years, more than 2 years of progression-free survival for the combination for patients with brain metastasis. Moving to another important part, I think that there is, this is the global cohort, but very recently were also presented some results of the Japanese cohort. That is a tiny cohort of 94 patients and 47 patients in the chemotherapy and osimertinib compared to the osimertinib only arm. And you can see here that the results in the Asian population and the global cohort are very similar. And osimertinib and chemotherapy is very similar to osimertinib and chemotherapy in the global cohort, suggesting that this combination is maybe not going with the race and is similar in the Asian, in the European, and also in the Americans. And moving, and you can see here again, this is the analysis set by Beaker, and as you can see, it shows exactly the same results again. And what we know also is that, you know very well that in osimertinib alone, apparently the osimertinib alone was better in the exon 19 compared to the exon 21, but you see that the exon 19 and the exon 21 are very similar in this population, suggesting that both of them benefit equally of the combination with chemotherapy. And again, if we look at the survival, apparently the survival can be even better in the Japanese cohort compared to the global cohort, but the global cohort here, as you can see, is still very, very early and immature. What we see also that is also the tumor response by investigator is similar. This is the Japanese cohort, and you can see that the depth of responses is higher compared to the single agent. And you see also that the median duration of response is 23.3 months compared to 13.8 months of osimertinib alone. You can see also that the global, the safety of the combination is very similar in the global cohort and the Japanese cohort, and there are similar number of adverse events treatment-related, and very few of them are serious adverse events that are related, and basically the majority of them are chemotherapy-related adverse events. What we know is that if we look at the differences, we see, as I said before, that the majority of the side effects are anemia, diarrhea, nausea, neutropenia, thrombocytopenia that are very common in during the chemotherapy, and very few of them are just related to the osimertinib toxicity. In particular, it's important to remember that 3% of patients had ILD, which I think is quite frequent in your regions, while 4% of osimertinib alone, suggesting that ILD is exactly the same also in patients with or without chemotherapy. And if we look at the results of the Japanese cohort, I think what is important is that in the Japanese cohort, there is more ILD with osimertinib and chemotherapy compared to osimertinib alone, which is higher compared to the global population. So this is just a warning to be careful with the ILD in the Asian countries. This is the second big and very important combination, which is the combination with lazertinib and amivantamab over osimertinib, and there was also another cohort that was lazertinib alone that was presented at the last WCLC in San Diego last year. As you can see here, we have the results of the overall survival, the updated overall survival were presented. And you can see that there is a benefit in terms of overall survival that at the time of the presentation was not statistically significant yet. And we heard from a recent press release that the Mariposa showed a benefit in terms of overall survival. I guess this benefit will be presented at ELCC next week. And as you can see also, there is a benefit also in the brain metastasis, but then maybe can be part of the discussion. My feeling is that the benefit in brain metastasis is higher with chemotherapy compared to the amivantamab lazertinib. If we look at the results, again, we see that the benefit goes across all the subgroups and is positive for exon 19 and exon 21. Also, if you see that in exon 21 is very borderline, and you see that the benefit more or less is everywhere. And if we look also at the toxicity, I think that this is important. Sorry if the slide is small, it's just a copy and paste of the New England Journal of Medicine. You see that I'm sure that you are familiar with the combination. This is a great combination, but the toxicity is not easy, in particular for the rash that is cumulative. Is difficult for the infusion-related reaction. Also, maybe if there is some improvement with the sub-Q. And there is also some paronychia. So sometimes for me, the most challenging part is the paronychia. And then there are also some other side effects that are related to the MET activity, like, for example, the peripheral edema that sometimes can be also big. So is toxicity that can be different from chemotherapy and osimertinib. And I'm also happy to hear your experience because sometimes it can be challenging for a patient to have this kind of toxicity. You have to start immediately with the antibiotics for some weeks, and you have to inform and to help also the patients to have a particular preparation of the skin during the time. So there is clearly a question. We have two combos that showed a PFS superiority. And you see that amivantamab lazertinib showed a benefit of 23.7 months, and osimertinib and platinum pemetrexed showed a 29.4 months that are corresponding to a very similar hazard ratios, 0.62 and 0.70. And so the big question is, how can we select who are the patients for osimertinib alone, who are the patients for FLAURA2, who are the patients for MARIPOSA? If we look at the results are also similar in terms of overall survival. The FLAURA2 has an hazard ratio of 0.75 and the MARIPOSA has an hazard ratio of 0.77. And as you can see, the maturity is different. There is more maturity for the MARIPOSA compared to the FLAURA2. And the MARIPOSA, as I told you before, showed that I think next week we will see the results in Paris, and there is the press release showing that there is an increase, a benefit also in terms of overall survival. So it is possible that both of the trials will be positive in terms of overall survival. The conditional power of the FLAURA2 is that is under this trend in 92% will be positive also in overall survival. And you will see that the MARIPOSA will be positive next week. So we have two drugs with two combinations with a different toxicity that will be positive for progression-free survival and overall survival. And so we will need to find a way to understand who are those patients who are for the osimertinib alone and who are those patients for the combinations. And as you can see here, I like this slide that was presented by Zsuzsa Piotrowska in 2023 during the first presentation of the MARIPOSA. And you can see that osimertinib chemo, amivantamab lazertinib, and osimertinib, you see that there are a lot of possibilities. If you start with osimertinib, potentially you can do carbo amivantamab like the MARIPOSA 2, or you can, if you start with osimertinib and carboplatin, maybe you can move to amivantamab. But you can see also that now we have the antibody drug conjugates, in particular patritumab deruxtecan and also Dato-DXd, that are coming in this scenario. And so what is great is that we have really a lot of opportunities to try to find the optimal strategy for each patient. So if we look at the results, the question is osimertinib alone dead? My opinion, I think that this will be a very interesting discussion also in the second part after my presentation. In my opinion, is dead for CNS metastasis. I think that for CNS metastasis, we should start with a combination, My favorite combination is with chemotherapy, and you see that there is also a difference in the hazard ratio 0.82 compared to 0.47. I think I like the combination when there is a lot of tumor burden. We have great data also for Mariposa, but we don't have data for the FLORA2. And I like also to use a combination in patients where there is a positive ctDNA and in general when we have some commutations. I think that is also interesting in the CDA negative, the length of the progression-free survival with osimertinib alone is very long. So in general, I don't like to use in patients with ctDNA negative the combination. So to summarize, I use the combination where I see a big burden of disease, sometimes when I see the commutations, and I don't like, and the CNS metastasis. I think it's important also to mention the Orchard trial and also the Savannah trial. Both of them will be presented next week at ELCC. And it is also possible that the combination with osimertinib and Dato-DXd, the antibody drug conjugate, will show a very high response rate and progression-free survival. I think that the abstract is already out, and I'm very curious to see all the results. But what you can see is that there are also multiple other combinations, one with savolitinib, one osimertinib and gefitinib. You know that the C797S is very active also with gefitinib. There can be a RET fusion, and there is the combination of osimertinib and selpercatinib. And I have seen also some ALK fusions, and so potentially you can also combine osimertinib and alectinib. We know that all of these combinations are active, and this is also important to do another biopsy after the progression, also in particular because some of the patients, when they progress, they have a small cell transformation and some activity in this setting. Moving to the KRAS space, I will present, this is the presentation, the final results of pembrolizumab and KRAS in PD-L1 more than 50%. I have already presented some preliminary results in this cohort, and the response rate in this population is very high, and the drug doesn't show a increase of toxicity in this population. Unfortunately, I can't show you the results, but you can see sorry, I have to go back. You can see the results of this presentation in a week from now on the website of ESMO and WCLC. There are also other combinations also for KRAS G12C. This is another trial that is called Sunray-02, and this is a combination with olomorasib and pembrolizumab and chemotherapy. Olomorasib can be combined with pembro only when PD-L1 is more than 50%, or we can combine KRAS, pembro, and chemotherapy all together, and the preliminary results showed that the combination is feasible and tolerable. And you can see, however, that there can be some anemia and there can be some thrombocytopenia, but surprisingly, there is not so much liver toxicity in this population that we know that when is combined with sotorasib can have some toxicity. If you look at the results of Merck, Merck has another KRAS inhibitor, very potent, and there are also trials comparing the KRAS inhibitor and Pembro compared to Pembro alone in PD-L1 more than 50%. And as you can see, there are also some data that in this population are combining, and also in the KRAS, not just in the KRAS inhibitor population, but here also in the EGFR population, are comparing sacituzumab tirumotecan over the chemotherapy. And here we have another EGFR trial that is comparing the Merck 2070 over docetaxel and pemetrexed in EGFR progressing after multiple, also after the combination, after chemotherapy, platinum-based chemotherapy in this setting. So this is another trial, again, in the KRAS space. Sorry if I mixed the KRAS and EGFR in multiple lines. And this is, again, randomizing olomorasib and Pembro, olomorasib, Pembro, and platinum. And you see that there are also very profound results, and they are showing an amazing response rate of almost 70%. So I think that I finished my time for my presentation before the discussion. But we see that we have a lot of combinations. All the combinations in general seem superior to single agents in terms of progression-free survival, and in the EGFR space also in terms of overall survival. But we have now a lot of questions. Are all the combinations right for all the patients, or we can find the right combination for each patient? And should we use combinations for all the other driver mutations? For example, if you have a patient with ALK, should we use combinations also in ALK, in ROS, and other patients? And are there patients for single agents alone? And toxicity is an important part, I think, of treatment choices, in particular talking about chemotherapy, but also with amivantamab, and now also with the combination with the antibody drug conjugates. So I think that we are in an incredible period with a lot of opportunities, but I think that also at the academic level, we should cooperate and work all together to think what we can do to improve the outcomes of our patients and also their quality of life. So thank you so much for your attention.